Hi, welcome to PH Insights presented by the Pulmonary Hypertension Association. Join us as we delve into patient stories, healthcare updates, and the latest insights on pulmonary hypertension. Thank you to our platform sponsor, J&J, for their unrestricted support of PH Insights. Sponsors do not endorse or participate in the development of program content.
Hello, and welcome to this episode of PH Insights. I'm Dr. Scott Olitsky. I serve as the Global Center of Excellence Outreach Director for Cure HHT, the International Foundation for Hereditary Hemorrhagic Telangiectasia, which we'll be talking about in a moment. I've been invited to guest host this episode by PHA, and today we're going to be discussing the intersection of pulmonary hypertension and hereditary hemorrhagic telangiectasia, or HHT as we say for short. And we'll talk with some guests about the importance between the connection and why this is important to the pulmonary hypertension community. I'm going to take just 30 seconds or so and talk about what HHT is before we dive into this episode. So hereditary hemorrhagic telangiectasia is a genetic disease of blood vessel development or abnormal blood vessel development. Simply stated, blood vessels usually have an artery, which brings blood away from the heart, then travels through a very fine meshwork of smaller arterioles we call capillaries, before going into a vein, which brings the blood back to the heart, and then the whole cycle goes around again. In HHT, there's a genetic mutation that affects the way blood vessels develop. And what happens is that this capillary bed, that small network of arterioles that join the artery and the vein, are absent. So arteries connect directly into veins, and they form things called arteriovenous malformations, or AVMs. We call these AVMs when they're in the larger organs of our bodies, like the liver, the brain, or the lung. And if they exist on places like the skin or the lips or the nose, we call them telangiectasia. So that's essentially what is wrong with the growth vessel development pattern in HHT. Because there are no capillaries, the high pressure system of the arteries goes directly into the veins, and we really weren't built to tolerate this. So at that junction, there's often bleeding because that connection is very brittle, very fragile. So the main consequence of HHT is bleeding from these abnormal blood vessels. So the most common symptom or sign is nosebleeds, but bleeding can occur elsewhere, which we'll talk about in a little bit. And as I mentioned, it's a hereditary disease. So it travels through families. It is what is known as an autosomal dominant disease, meaning that you only need one gene copy in your DNA makeup. If you have that mutation, you have the disease. Regardless of whether you show signs or symptoms of it, you have HHT. So that means a parent who has HHT, each of their children has a 50% chance of getting it. And we'll discuss the genetics a little bit more throughout this episode. So enough about the basics of HHT. We thought it would be a great way to discuss this connection by introducing two important guests that'll be joining me today. Marla Olitsky is in Florida. Monica Penaranda is in California, where I am. And they have graciously said that they would share their journeys with us and what they've experienced learning about both of these conditions. So I want to thank you both for being here today.
Thank you. Thank you for having us.
Thank you.
So we'll get to know both of you quite a bit. I think maybe we'll start with Marla, who, as people can probably guess, is my cousin. And again, she lives in Florida. We thought maybe their paths are somewhat similar and somewhat different. Marla will talk about her HHT path first, and then we'll come back to her PAH path in a moment. So Marla, tell us a little bit about your HHT history.
Thank you, Scott. Well, my HHT history really, I didn't even know I had HHT. I knew nothing about it. I didn't think it impacted anybody in my family's life. But my dad carried it, as well as my grandfather, my great-grandfather, and my uncle and my cousins. So we were all affected by that dominant gene. For them, HT meant nosebleeds and how to control them. But for me, it was a quiet presence. I never even had anything to do with it until later on in life, probably in my 30s, but I wasn't showing any signs or symptoms. So we didn't talk about it until when I developed PAH.
I think it's interesting because Marla notes that she didn't have any signs or symptoms. And so Marla mentioned our grandfather and great-grandfather, who everybody grew up knowing had nosebleeds. And like a lot of families, we just assumed nosebleeds were typical for our family. So we'll come back to your PAH story in a moment. We're going to look at the other direction with Monica. Monica is back on the podcast. I think she may have been the first person, or at least one of the very first people on this podcast. So we were hoping she could reintroduce herself and tell us about her PAH story before we come back to her HHT story. Hi, Monica.
Thank you, Scott. This is very different for me because it's so new, but telling my PH story is I'm very used to that portion of my life, and the HHT portion I'm very new at. But 28 years ago, I went into the ER with a massive nosebleed. We couldn't control it. It was about 3 days where it was just every time we tried to see if it was under control, it would just start gushing again. I had it plugged. And so I ended up in ER. I was pregnant and I was having chest pain. So as a result, they decided that it would be best for me to go in and get checked. They did an EKG, and the EKG showed that something was incredibly wrong with my heart. It was enlarged, and they went ahead and did multiple tests. And through that stay, I found out that I had pulmonary hypertension. So going back to that nosebleed, it was just a nosebleed that caused me to have heartburn. And the heartburn triggered the reasoning to get that EKG. And because of that heartburn symptom, I was diagnosed with pulmonary hypertension correctly, which is very uncommon. A lot of people are misdiagnosed for a very long time. And I was very fortunate to be diagnosed early on. My story didn't end happily. I ended up in the hospital in my 5th month, and I went into a coma, and my baby went to heaven, and I was officially diagnosed with pulmonary hypertension. That was the beginning of them fighting to keep me alive. It was a hard hospital stay. I don't recall a lot of it. I have no memory of a lot of stories that my family and friends tell me about that time period, but I was able to get stabilized over the phone at the hospital that I was in, and I was transferred by ambulance to UCLA. And my doctor at UCLA, who stabilized me over the phone, was able to begin the work of saving my life. And I was put on the very first treatment for pulmonary hypertension. It was given through a pump and had to have ice packs and be kept cold. And it was literally an incredibly different view of what my life was like before. If I could look into my future, I would never have imagined that I would live this long, that I would make it this far at 28 years into my diagnosis. That was 23 years longer than they gave me. So I'm very blessed to still be here today.
I urge people, if they haven't listened to that first podcast, to go back and listen to it. And we applaud you for being so strong and such a leader in the community. It's very much appreciated. So Marla has HHT and now diagnosed. Monica has PAH. Unfortunately, the story doesn't end there. Marla, tell us about what became your PAH journey now.
I was a marathon runner, and I was training for my 4th marathon. Noticed at that time I was running about 12 miles a day, and I noticed very quickly actually that I wasn't able to run as far. I had to stop and take frequent breaks, and I realized by the time I couldn't even run to the end of the street anymore that I better get checked out because I wanted to keep running. So I sought out a pulmonologist who actually he did a great job diagnosing me with PAH. And that's when I found out that I had HHT, actually. Well, that's when my symptoms of HHT started showing up, as he put me on blood thinners. Because 17 years ago, that was one of the course of treatment, was to go on blood thinners. So at that point, I was in and out of the hospital. I had some iron infusions. So at that point, I was recommended an HHT and a PH doctor who was able to manage my HHT. There were no treatments, but we were able to manage the nosebleeds with some sclerotherapy. And that was in the office. But before that, we had to go into the hospital and go under to treat the blood vessels in the nose. So That is how I found out that I had HHT with the PAH. And now with seeing HHT doctors who also manage PH, we are able to kind of get a hold of the nosebleeds and manage the HHT at the same time as the PAH.
Great point that we'll talk about in a little bit is the challenge in the medications between the two diseases, where one can help, a medication may help one disease, but make the other disease worse. Yeah, we'll certainly talk about that a little bit. Monica, I know your HHT diagnosis is a little more recent than 17 years PAH diagnosis for Marla. Can you tell us about that?
Yes. So it's funny because although it's a brand new diagnosis, the symptoms are not brand new. I had my very first nosebleed as an infant, and my mom recalls the story of when she walked into my nursery and there was blood all over the walls, the crib, myself. She thought she entered into a horror movie. Literally, my nosebleeds have been a part of my life from the very beginning. And I was born with a huge strawberry patch on my wrist down to my arm. We never thought anything of it. We called it a strawberry patch. It's just a big, red, huge blot of an area. And I've always had red, as I would say, dots on my body and just never really thought anything of it. But my whole family, there's 9 siblings in total, and almost all of them but one have all had those symptoms. And all my cousins, it's like a regular conversation we'll have over the dinner table. Oh yeah, I had a nosebleed this morning. Yeah, I had one in the car. It's just kind of, we always said our veins were close to the surface, quote unquote. We didn't really know. But I have an uncle that was diagnosed officially a few years after I was diagnosed with PH, but still I didn't seek out diagnosis. I feel like I put HHT, or the idea of it, in the back burner because managing PH was just as much as I could handle at the time. So I didn't seek out another diagnosis basically and just left it behind me. And then I have a cousin who was diagnosed, and her kids, and they went through the genetic testing and they found the mutation. I have a cousin that had to have a couple of procedures in his lungs and one that had a mini stroke. So it is very prevalent in my family. But it took me being on social media and saying to another patient, giving advice on how to help a nosebleed, and for someone to acknowledge that I had all this knowledge of nosebleeds, to ask me, hey, by chance, do you have HHT? And my reply was, yeah, probably. It runs in my family, but I don't really know. And so that was the start of Scott actually reaching out and asking me that question. And I'm so grateful to you for getting me in touch with a specialist here. And my diagnosis went pretty fast. And because I already had the mutation from a cousin, I was able to have the testing done easily, and what I've heard, a lot faster than most can. So I've just learned to deal with all these nosebleeds, and I've had some pretty gnarly bleeds. I remember a time when I went to cheer camp in San Diego, and my parents had to come and get me. There was no more tissues to hold my nose. And this might sound really crazy, but one of the cheer coaches actually went and got a Kotex, and I was filling up Kotexes just with blood, and it was pretty intense bleeds. So now that I'm officially diagnosed, I have been able to learn a lot more about it. And now I think my goal is to learn as much as I can so that I can prevent these massive nosebleeds, and then also try to help my family with more of them, learning if they have it or not.
Yeah, that's terrific. Thank you for that story. There's a lot there that I think is really important. Whereas Marla and I knew about this disease, we knew about it even back to my great-grandfather. So it was just taken for granted. We had nosebleeds, we dealt with them. But I think people listening who don't have HHT might be thinking, these nosebleeds sound horrific. How do they go undiagnosed? Well, when half the family has these nosebleeds or these red spots, you just kind of think it's something everybody has. Nobody thinks twice that I had 2 or 3 nosebleeds today, or I, used up a whole box of Kleenex with a bad nosebleed, or some of the horrific scenes I think every HHT family has seen in the bathroom when they have a bad nosebleed in the middle of the night. That's how it goes undiagnosed. And one of the important things that we hope a podcast like this will help with is we believe that only 10% of the people with HHT are diagnosed. So there are a lot of people who are undiagnosed, and we need to get them diagnosed. And likewise, people with HHT, up to 20% of people with HHT develop pulmonary hypertension. Many of them due to HHT issues with the liver and heart, but about 1% develop pulmonary arterial hypertension. And as most of the people in the PH community know, delayed diagnosis is a horrible thing, and it's very common. And hopefully in the HHT community, bringing awareness about PAH and pulmonary hypertension will help decrease that delay. So people like Marla will have to seek multiple people before they get an answer. And likewise, we want the PH community to know about HHT so that people like Monica can get not only themselves, but their family tested, because there are life-saving screening events that need to take place, which we'll talk about. So why are we doing this podcast? One is it's HHT Awareness Month in June. So Cure HHT and PHA have a nice partnership where we help raise awareness of each condition. And there's a lot of exciting developments coming up in HHT and PAH, some which will interconnect the two diseases better. So I thought it would be interesting. Why do some of these delays happen in both communities? And if we take a look at HHT first, I think, again, the people in the PH community are well aware of what the typical early presentation signs are and symptoms of having pulmonary hypertension. But in the HHT community, those signs and symptoms are also quite common, and most of the time it's not pulmonary hypertension, it's HHT. So things like being anemic. I mentioned that HHT, the blood vessels, the abnormal blood vessels bleed. HHT is a bleeding disorder, and although there's some discussion about that, it is not a coagulation problem. There's not a problem with our blood coagulating. There's just a problem with these fragile blood vessels bleeding. And it happens to be the second most common inherited bleeding disorder, but it doesn't receive the recognition that it should. HHT occurs in about 1 in 5,000 people. That's about what the incidence of cystic fibrosis is. Every physician knows cystic fibrosis. It's a pretty small minority that knows what HHT is, so we're trying to change that. So patients tend to be anemic. More than 50% of HHT patients are anemic. And if you're anemic enough, you feel short of breath, you're tired, many of the things that people in the early stages of pulmonary hypertension will feel, and that get worse as their disease gets worse. The other thing is oxygen saturation. I don't have to tell the PH community the importance of monitoring oxygen saturation, being short of breath. But in the HHT community, many of us have pulmonary AVMs. These are AVMs in the lung, which bypass blood getting oxygenated in the lung. If the AVMs are large enough, or if you have enough of them, your oxygen saturation can be low. It can be in the 60s and 70s. You can experience exercise intolerance like Marla did. So it's very easy, especially in patients with known lung AVMs that may not be large enough to treat, but patients with lung AVM, they complain about being short of breath, and it's chalked up to having the lung AVM. And it could end up being something else. So again, it's another reason why the HHT community needs to know more about pulmonary hypertension. And we'll get into this a little bit on the PH side, but how do we diagnose lung AVMs? The screening test we use is a bubble echo, an echocardiogram where saline bubbles are injected. And some in the PH community have probably had this done. And if the bubbles are seen to cross from the right side of the heart to the left side of the heart, there's a communication there. Now, most of the time, that's something called a patent foramen ovale. Many of us have that. It occurs in about 25% of the population. It's an embryonic defect that doesn't go away. But lung AVMs will also produce a positive bubble echo. There's some subtle differences in the way they're read. So for people who are used to reading bubble echoes, it shouldn't be hard to differentiate. But I have certainly run across a number of patients who were told that they have a PFO, and it really is a lung AVM. And the importance of that is 70 to 80% of people with a lung AVM have HHT. It's overwhelming the major reason people have lung AVMs.
So to clarify, just so I understand, does that mean that there could be quite a few people in the PH community that may have gotten PH because they had HHT and it just went undiagnosed and they only saw the PH part of it?
Yes, I've run across probably a dozen patients so far who did not know. And those are patients that I talked to, like you, who we found out had HHT. But there are, I'm sure, many other patients out there who don't know they have HHT. So PAH, so if you have HHT, as I mentioned, have about a 1% chance of developing PAH. So the PAH may make itself known years, decades before somebody figures out it's HHT. And we're going to talk about genetic testing. You mentioned that with your family, but some physicians do genetic testing in newly diagnosed PAH patients, and the HHT genes are actually tested in that panel. So you would know if you have HHT if you get genetic testing.
I just want to make a comment about when you were
Sure.
talking about the HHT and the PAH characteristics are very similar. There was a time not that long ago, probably about 7 years ago, I thought that there was something wrong and there was something going on with my PAH, and I knew that I had to get to my doctor as soon as possible. And I got there and everything tested fine, but my hemoglobin was a 6. So, and I thought it was my PAH because I was short of breath. I couldn't climb the stairs. I couldn't carry a backpack and walk.
I have a similar study climbing a mountain with a hemoglobin of 8. I just thought I didn't train well enough to do it. And, 12,000 feet, having a hemoglobin of 8 is not too good for you. So we've all been there. And the problem is we have these nosebleeds. They get a little worse. Certain times of the year, they might get worse. You have a bad one, and you just don't think about it. People with HHT have GI bleeding, which can be very subtle, very slow, a small trickle, but over time, it adds up and you can become anemic. I have something I say to HHT patients: you don't know how bad you feel until you don't feel bad anymore. It's a slow process. I'm sure I know the answer to this. Once you got that hemoglobin from 6 back up to a normal range, then you realize how horrible you felt.
Yeah, now I feel like I know what to look for. However, you never know. Yeah.
That's so common in the PH world. We're so commonly used to not feeling good and pushing through that we don't realize that we really don't feel good. And we should maybe get checked again to just make sure that our meds are correct or
Right.
obtaining extra fluid. Or maybe there's some things that they could do to help us, but we just get so complacent in how our body's already so crappy. So what's the difference? But we don't realize that there might be something our doctors can do. So it's so important. If you have to take your diagnosis, take control of it and say, no, I don't want to be content feeling this way. I'm miserable. I want to feel better, and go at it. Talk to your doctor and figure out that we have so many different treatments now. And sometimes we don't realize we could try something different, and it's okay to ask. But I think the key is ask and go for it, and don't be complacent.
Advocate for yourself. You know how you feel. And sometimes things are very subtle on testing, but you know how you feel. And it's important to advocate for yourself. And we'll get into some of the issues with having the two diseases. But, with PAH, your heart is already stressed. So if you become anemic, and for some people, it doesn't have to be very much. It doesn't have to be 6, which is really anemic. It might be 8 or 9 or even 10. Now you're putting extra stress on your heart. And if you have PAH, that combination is really, really difficult and really puts a lot more pressure on your heart, so to speak. So if we kind of look at it the other way, if you have PAH, what things could be happening that might be HHT related, or at least should maybe think about it? As I mentioned, by far the sign that is present most in HHT patients are nosebleeds. 90% of people with HHT get nosebleeds. Now that's really important because 10% don't. And we'll talk about the family member that says, I don't have HHT because I don't have nosebleed. Well, you could be one of the 10%. So we'll come back to that in a moment. But if you have PH, you may be on some drugs or be doing things that would explain the nosebleed. And in 95, 99% of cases, they probably do. Maybe you're on anticoagulants. Maybe your blood pressure's high. Maybe you're on oxygen and your nose gets dry. These things can all explain nosebleeds. And this is an important but. Did you have those nosebleeds before you got diagnosed? Did you have nosebleeds before you were put on PAH medications? The vast majority of medications for PAH work by dilating blood vessels.
I've noticed that I started a new treatment. It'll be a year on June 10th that I started it. And since I began that treatment, I've been able to decrease one of my main drugs that I've been on for decades. And I've noticed coming down from them, my nosebleeds have lessened or they're not as bad. I might have more of a trickle or just I see like more of a dab or maybe dried blood when I wake up. I'm one of those people with a little mini flashlight looking in, making sure. But I've noticed that when I started that new drug, the nosebleeds worsened. But then when I started decreasing one of my old drugs, the nosebleeds got better. So, I mean, I'm not a doctor. I'm only a patient and I can only tell you what works for me or what happens with me. And I've noticed when my nosebleeds worsen or they start picking up again, I dial back on my medication a little bit. And that's with the approval of my doctor. And they completely know it's a team effort. And the nosebleeds, they decrease or they lessen in severity.
And I think most people with both diseases have noticed this. And it might give you an opportunity to talk to your doctor because some of the PAH medicines probably are more effective than others, I think is safe to say. And others are more likely to cause bleeding if you have HHT. But it's a fine line. I know, Marla, you've kind of gone through this yourself as well.
Yes, I have. As a matter of fact, I've been with the medication that I had been taking for 15 years. And my doctor's like, well, why don't you stop that and see what happens? And I'm the kind of person where if it's not broken, don't fix it. So to take away a PAH drug for me is like detrimental because I knock on wood of the way that I'm doing now. I don't want to change anything, but I did. And my hemoglobin went up 3 points. And I feel exactly the same.
I think that is a perfect lead into why is it important if you have PAH to know you have HHT. One is some of the medications might be, maybe there's a better way to tailor them specifically for you. Because as I mentioned, if you have PAH and HHT and one of these drugs is leading to increased anemia, either maybe a drug can be discontinued or lowered in Monica's case, or maybe another medication which is useful for HHT bleeding can be added. There's a number of PAH, HHT patients who are able to add medications which are used in the HHT community to help with bleeding that have been very successful for them.
Just coincidentally, something popped into my mind. There is a drug that I know increases your hemoglobin. But so if somebody is low on the hemoglobin, I wonder how that would help them. But then it probably also increases HHT symptoms. So there's like that fine balance, but it's just, you don't know how your body will react unless you try something. And I think not being afraid to try is also really important too.
Yeah, that's a great point. And I think another thing, hopefully, with increasing the awareness and the connection between these is allowing people with both diseases to tell us about their journey and find out that maybe there's a medication that people have been worried about using in one disease or another, but it actually works very well. And it might help other patients learn about that and their physicians as well and offer them some more options in treating one or both diseases at the same time. The other reason we wanted to talk about this is about diagnosing not just the patient, but why it's important to diagnose the patient so we can diagnose other people. As I mentioned, HHT is an autosomal dominant disease. So when you find one person, you're going to find other family members. And why do we want to do that? Well, one, it may explain certain things. It may explain why somebody's anemic. It may explain why people are having these nosebleeds that are either medically challenging or socially embarrassing. But it can also save lives. And I'm not saying that to be hyperbolic. HHT, for the most part, can be managed. Life expectancy is typically normal. But there are certain things that can happen that can be catastrophic in patients with HHT, the vast majority of which can be prevented or at least limited through proper diagnosis and screening. So when we have a patient that we know as HHT, it's very important to test family members. HHT can be diagnosed in two ways. One is clinically through something called the Curacao criteria. Let's just say that somebody who is well aware of how to make the diagnosis of HHT for many patients can make the diagnosis clinically. But then there's the genetic testing. There are several genes which cause HHT. And as I mentioned, if you have the mutation in one of those genes, you have HHT. And so typically what is done, somebody like my father who had HHT, we knew about that for many years. We knew I had HHT. We knew had other family members did. He was genetically tested. We found his mutation. That's the hardest mutation to find. And we find it in about 90 to 95% of patients that are clinically diagnosed. Once you know that exact mutation, like Monica, I think you mentioned your uncle had the mutation, everybody else in the family who could be connected to that person can be tested. So all of Monica's uncle's siblings should be tested genetically. And if there's another uncle who tests negative, none of his family has to worry about it. It can't skip a generation. But everybody who tests positive, then their children have to test, and then their children have to test if they're positive, and so on and so forth. And so that's typically what we do with the genetic testing. And the reason we do that is because I mentioned AVMs can form in larger organs, liver, brain, and lung. The liver, the brain, and the lung are what we worry most about from catastrophic events. So bleeding, hemorrhage causing stroke, infection in the brain. These AVMs can be treated. The vast majority of them can be treated. The only thing worse than hearing a horribly catastrophic story about a family member, somebody's sister, child, who literally dies because of a hemorrhagic stroke. The only thing worse than that is knowing that family knew they had HHT and didn't get tested. So it's imperative that all the family members get tested. And I know, Monica, you mentioned that your family's going through that process now.
Yes, but I do have questions on that. But I do have quite a few of my cousins have reached out and said, okay, what are my next steps? I didn't really know what to tell them other than go to your PCP and tell them that you have HHT that runs in your family. But what's your best recommendation on how to properly go through? One of my cousins said, hey, Mon, what do I do next? What should I say?
Yeah, so it's a good question. So typically what it would mean is asking your PCP to write an order for the genetic testing. And there are several labs around the country. You can find them on the Cure HHT website. You can email the foundation. They can give you information. So typically the PCP writes an order. It goes to a laboratory. They send you a kit. Usually it's just a saliva kit. So you can test very young children. You collect the saliva, you send it back by mail, and they run the test. As I mentioned, if you already know the mutation, you just send the lab the mutation. That's the only one they have to look for. They don't have to look through all the genes and all the DNA. If you don't know the mutation, it'll take a little bit more time, but they'll still find the mutation 95% of the time if you have it. Does that answer your question?
Yes. So being that you helped me and got me in contact with a specialist locally here, that specialist made me an appointment with a geneticist. And I went through a geneticist to get everything done. So you're saying that they don't have to go through a geneticist. They could probably just go through their PCP in that case. And if they say, oh, here's the mutation that is in my family, and the PCP can do it.
Yes, they would have to be comfortable talking to you about the genetic results. But some of these labs also have genetic counselors as part of their program, so they can talk to you about that as well.
Well, that's great to know.
People say, how early can you test? Well, you can test on the day of birth, and we actually advocate for that. Some people say, well, we don't want to know so early. Well, we've had infants die of strokes. It's really, really important. And why is it important to test? Because bubble echoes, if you know you have HHT, you should be getting regular bubble echoes, and that's important for two reasons I'll mention. One is to look for lung AVMs. If you have a lung AVM, not every lung AVM needs to be treated, but if they're large enough that they pose a risk, they're treated through an embolization process, much different than it was decades ago where they would have to remove part of your lung. Now it's done through a catheter that's placed, much like getting a right heart cath, and they're treated that way. So that's good to know. The other brain AVMs need to be screened for with brain MRIs. And the other reason the bubble echo is important is because once you know you have HHT, you need echoes every so often. And if you were to be one of the 1% that develops pulmonary hypertension, you may catch that pretty early on an echo before you get symptoms, hopefully.
Well, that makes it a lot less scary hearing how you explain the procedure in the lungs, because I just kept envisioning, how do they do that? And I think knowing that you can have something minimally invasive, I think it's still invasive, but minimally invasive, and that could save your life, would make you want to make sure that you're being screened.
Yeah. And I'll just point out, this is getting a little bit more advanced, but I'll just point out pulmonary AVM in HHT, if you have PH, are very complex. We have certain guidelines most people abide by for HHT. But if you think about the pulmonary AVM in the PAH patient, it's almost like a pressure valve. It's allowing some of that pressure to come off. So one of the things that can be worrisome is if you close a pulmonary AVM in a PAH patient, that the pressures will go up. So this is a very delicate situation that should be dealt with by people who understand both diseases at the same time. Unfortunately, we've heard about patients with PAH getting lung AVMs embolized and then developing problems because of that. And sometimes they have to be, but there might be some situations where if you have PAH, you may not want that lung AV embolized.
I had something similar happen with me with ISD, and they didn't close it completely because it's acting like a pressure valve. But I would be doing a disservice to the PH community if I didn't ask this question, because it's in my mind and I have no clue if there's any connection. But being that we're talking about AVMs in the lungs, could there or is there a connection between CTEPH and PH? Could HHT cause that and become pulmonary hypertension? Do you know?
I do know what you're trying to say. And I will say this. So HHT patients bleed, but conversely and somewhat ironically, when you're anemic and you have HHT, that there is an increased rate of clotting in some HHT patients. So whether or not that, and pulmonary embolism. So whether or not that could lead to CTEPH, I don't know. But clearly as an HHT patient, if you're anemic, but you tend to have these clotting issues, theoretically, yes, you could at least develop clots in a similar fashion. I don't know if it would lead to CTEPH or not, or if that's been described.
Thank you.
And then the problem is anticoagulating the patient, as Marla mentioned, with HHT. It can be done. It needs to be done by a hematologist well-versed in HHT because it's a very delicate situation. But that'd be another place where you absolutely want to know that you have both diseases if you're going to be anticoagulated.
Yes, and I've been there too. I was on blood thinners for the first 17 years.
We face this a lot in patients with atrial fibrillation. Unfortunately, in HHT, it's fairly common.
Scott, you had mentioned earlier about oxygen and nosebleeds in PH patients. Can you explain a little bit more about that if they are showing symptoms of the nosebleeds before they started the oxygen?
Sure, yeah. As I mentioned, a lot of people on oxygen get nosebleeds because of the dry air, and it could simply be the oxygen. Now, it could be people with HHT on oxygen also get nosebleeds more readily for the same reason, the dry air. I think if you're sitting there after this podcast wondering about those nosebleeds, and could this be a sign of HHT, I would say, ask yourself, did you have nosebleeds before you were on oxygen? Monica mentioned that she did. Now, nosebleeds, many people with HHT may not get them until they're in their 20s. So the answer might be no. The other thing to ask yourself is, and Monica referenced this, anybody else in the family with them? We hear this all the time, HHT people, yes, I have the nosebleeds like my father, my grandfather, my uncle. They don't even think about it as being abnormal. But if you're sitting there now thinking about it and you're getting nosebleeds while you're on your oxygen and you have an uncle or an aunt who gets nosebleeds out of nowhere, well, that should definitely raise a suspicion. At the University of Utah, they did a study and they said, how many nosebleeds does the average person have compared to the average HHT person? And their number, forget if it was 3 or 4 a year. Now, HHT patients can get 3 or 4 in the morning. So they said if you have more than 3 or 4 nosebleeds a year, the chance of you having HHT is, I think, over 95%. It's really high. Now, that was the normal population. That doesn't include patients on anticoagulants, include patients on oxygen, which are going to have a higher rate. But if you had nosebleeds beforehand, or you have family members where you get them many times a day and you're not on anticoagulants, or maybe even if you are, at least be thinking about it and talk to your doctor. As I mentioned, the clinical diagnosis is pretty easy. Monica mentioned the little red dots she had. And the same study showed if you have 2 of those little red dots, we call telangiectasia, on your fingertips, on your lips, your tongue, chances are you have HHT. The average population doesn't have telangiectasia on their skin. So if you're sitting there with nosebleeds from your oxygen, maybe a family member, but you have a couple red dots on your lips, it definitely warrants a discussion with your doctor.
I can tell you, I just did the test not even a year ago, and it was just a little bit of spit that I put in a tube and sent it off into the mail and got my results. So anyone can do it.
I hope you're not seeing this in your family, Monica, but we hear about it from other families. A lot of patients don't want to get tested. They're worried about what it might do for insurance. Well, fortunately, health insurance now can't be excluded because of the pre-existing condition, fortunately. But what I tell people is, if you're not going to do it for yourself, do it for your children, because you don't want to know that you could have prevented a tragedy by getting tested.
That is so heartbreaking. I just can't even imagine. It just makes me cry. And it makes me want to jump up and get all my family tested right now, hold their hand and just do it.
I understand. We get calls every month about somebody, and it's tragic. And it's even more tragic when you know your family has HHT and you didn't get screened. I guess to wrap up, we'll leave it with the importance of screening and also with some hope. There are some fantastic medications coming out for PAH. There are some out now for HHT that, Marla, my grandfather and great-grandfather didn't have options for. And there are some that are coming out that may be very helpful to treat both diseases at the same time. So this is a time to really look towards the future, I think, favorably. There's some really good stuff coming up for the community, but it starts with awareness. It starts with people thinking about both diseases. If you have HHT, whether or not you might have PAH and vice versa, and getting yourself tested and getting your family tested.
There's one thing I always tell fellow friends, PH friends, HHT now, my new friends. It's so important to not just think that your life is in your medical team's hands. Your life is in your own hands. So arming yourself with knowledge so that you can better advocate for yourself is so important. And if I could give anyone any advice, it would be arm yourself with knowledge and then go to bat for yourself.
Absolutely. Go to the PAHA website, go to the Cure HHT website, learn about the diseases. Both websites have information for newly diagnosed people or for people who are wondering about the diagnosis. But I agree, Monica, your physician team is there for you, but you have to be there for you and your family as well. I want to thank both of you for this. I hope it empowers the community, and I hope we help awareness with both diseases. I hope next time we talk on a podcast like this, we're going to have some more great treatments, medications, and better understandings of both of these diseases, and especially how they interact with each other.
Thank you, Scott, Marla.
Thank you. Thanks, Scott. Thanks, Monica.
And thank you for listening to PH Insights presented by the Pulmonary Hypertension Association. Remember to subscribe and to join us every second and fourth Wednesday of the month for more valuable insights. And thank you to J&J for their unrestricted support of PH Insights.